So today we're going to talk about hypertension. Okay. Now this is you've been doing virtual stuff for a couple of years now, huh?
Yes.
We are not used to the interaction, so this might be a long time since you interacted. I like interacting with people. Okay, asking questions. Hypertension is a relatively straightforward subject. There's a few things you guys want to know, but the few things I want you to know, I definitely want you to know. Okay? So when we talk about hypertension, what are we talking about?
Blood pressure.
We're talking about the force of blood pushing against the arteries. That's what we're talking about. So the arteries, we have a force of blood pushing against that, and when it's persistently high, we call it hypertension. So that's what we're talking about now. So it's systemic vascular resistance versus cardiac output. Now, why is it important? So, 1,000 deaths a day with hypertension. 7 of 10 people have their first heart attack, have hypertension. 8 of 10 people who had their first stroke, so heart attack, stroke, death, all these things are bad things for hypertension. Now, as we said, it's either increase in cardiac output or increase in peripheral vascular disease. Now, hypertension, when we talk about hypertension, a definition, meaning when you put the cuff on the arm and you inflate, when will you call this hypertension? Okay? So there is 10 definitions, 10 kinds of the European, the international, old ones, new ones, books, different variables. What I'm going to use today, so it will be clear which definition we're using, is the American Heart Association, published 2017. 2017, American Heart Association decided to establish the normal numbers. Is it better than the others? Maybe, maybe not. That's a matter of a lot of debate. We want to make things focused. So we're talking today about hypertension according to the American Heart Association. So what's the definition? So stage 1, what is hypertension? 130 to 139 or 80 to 89. So if you look at other books, this is considered a lower number. Okay? Stage 2 is plus what most people know as hypertension, other resources. So more than 140 or more than 90. American Heart Association already calls 130 or 80 hypertension. Hypertension. Okay? Now, the normal is less than 80 or less than 20, and elevated is before that. Smart screen. Too smart for me. So elevated is 120 to 129 and less than 80. Okay? And this is based mostly on a sprint trial. That's why they change everything. Sprint trial showed that when you get patients' blood pressure lower than 130, then you get clinical benefit, reduction in all-cause events. And that's what guides us. And that's why American Heart Association decided to go ahead with this more aggressive recommendation. Yes?
It's independent of age.
What's that?
Independent.
Independent of age and dependent of comorbidities. Okay? This is the definition of American Heart Association. You say, okay, this is what it is. Absolute numbers. Okay? Yes?
Can we consider elevated blood pressure pre-hypertension stage?
Okay. So so that's why I want to focus things on the vocabulary we're using here. Okay, so American Heart Association is calling it elevated blood pressure. Okay? The pre-hypertension is the definition that with the J's and a lot of controversy, we don't get into that. We're going to call it elevated blood pressure, less than 120 called normal, and then the stages I said earlier. Okay? Clear? 2017 American Heart Association guidelines. Okay, so we're gonna have a little more time for questions, but for now,
Can you use the mic deficit?
what's that?
The mic.
I prefer now. No, the small class. If anybody doesn't hear me, I think everybody's gonna hear me. No worries. Okay. Okay. So primary hypertension. What do we mean by primary hypertension?
Idiopathic.
Okay. So there's no cause. The majority of people with hypertension do not have a cause. There's no cause. You go there, they measure your blood pressure, randomly walking in your clinic, and their blood pressure is elevated. Okay? That's what it means. No causes. You do all the evaluation, everything you want to do, and then there's no cause. So when a patient walks into your clinic and tells you, why do I have hypertension, you know that you most of the time will not have an explanation. Okay? Most of the time, you will not have an explanation for hypertension. Idiopathic. Okay? Now, it's 90%. Who are the patients who you will look for a definite cause? What's that?
Secondary hypertension.
Yes. So secondary hypertension. The patient walks into the room. Usually, most of the times, they won't have a sign saying secondary hypertension. Okay? They'll have hypertension, and you'll have to figure out why they have hypertension. What are the clues that will make you think is this patient particularly has secondary hypertension? As we can see, this is less of 5%. What we mean is in 20 patients who walk in your clinic, number 19 might be the person who you want to have a correctable cause or a secondary cause. So what are the things that you think about it?
Acute presentation.
What's that?
Acute presentation.
What do you mean by acute presentation?
Sudden hypertension.
Okay.
I think the first thing you need to look for is the age. Anyone above 55 would usually have a secondary cause for hypertension.
No.
Smoker.
No.
Someone who's age
young
less
patient.
than 25.
So the opposite to an old age.
Young.
So young patients, you worry that this is secondary, not the old. Elderly, at some point, 30% of people have hypertension. At some point. Okay? But the elderly, yes. Okay? So one thing is going to be age, young age. What else?
Drugs.
Drug induced.
No, well, if he uses drugs, then you want to look at the drugs. Sometimes
Obesity.
medication increases.
Obesity.
Obesity, okay.
Pregnancy.
If he has any symptoms associated with pain.
Okay, so association, what's that?
Renal failure.
Renal failure. So renal failure is a secondary cause. What else?
Hyperthyroidism.
Hyperlipidemia.
Hyperlipidemia is an association. These people with hypertension, diabetes, and dyslipidemia, they come in bundles. So they all come together. They're all at risk of having bad things, heart attack and stroke. But it is not a secondary cause. One type of secondary cause is young. The young. Second is hypokalemia. So if a patient, you do routine blood work, has low potassium, this is a cause that makes you think this is secondary hypertension. Okay? What else? So what is pheochromocyte? So it's excessively rare disease, but how do you know this is the guy who has pheochromocytoma?
Sweating.
Cancer.
Okay, so episodic, very high. But in a more broad way, if you have a patient that you give them 3 antihypertensive medications and still hypertension, you worry about secondary causes. Okay? So a guy who's young, unusual. A guy who has hypokalemia, unusual. A person who has very resistant hypertension is stuff that you worry about for secondary. Okay? Questions?
What about pregnancy?
Well, pregnancy is a whole different thing. So a patient comes in, she's pregnant, you look for preeclampsia at a certain time. You know, that's part of the how you risk stratify. Now, a patient has preeclampsia, she has a risk of hypertension, that's also possible, but that's a different story. Now, you have a patient walking, male or female, and you want to worry whether the patient's primary hypertension, the most of the people, or is it secondary cause. Secondary cause, you need a lot of more investigations. Okay? You're not going to be doing a 24-hour urine test for the catecholamines for every patient who walks with hypertension. You're not going to do that. You're not going to do renal ultrasounds for anybody who walks with hypertension. You're not going to do that. You will do that if a patient who's 20 years old comes in with hypertension. You will do that if a patient who walks into the room, you started a blood pressure medicine, still hypertensive, another one still hypertensive, a third blood pressure medication, and his blood pressure is 160. You will definitely want to do that for them. Renal ultrasounds, you will do 24-hour urine for catecholamines and other causes for secondary hypertension. Okay? So these are the people I want you to worry about. Okay? So what's the most common cause of secondary hypertension? What's that?
Young age.
No, what's the most common cause?
Genetic?
What's that?
Genetic?
Okay, so genetics, and these are causes for hypertension in general, which is multifocal. But I'm looking for a disease. So what do we mean by primary? Primary is that's it, hypertension, nothing else. Secondary, there's another disease that could be treated that is causing hypertension. So hyperthyroidism is one of the causes, but it's not the most common. What's the most common?
Arrhythmias.
What's that?
Arrhythmias.
No, arrhythmia is a problem that results from hypertension, but it's not a cause.
Kidney disease.
So kidney disease, so acute renal failure. And we have hyperthyroidism. What else? Primary hyperaldosteronism is another cause.
Renal artery stenosis.
Renal artery stenosis is another secondary cause. So what do we mean by secondary cause? For example, when somebody says a primary hypertension, okay? You look at the renal arteries, they're normal. You look at the catecholamines, they're normal. You look at all the blood work, they're normal. Primary hypertension. Secondary, you do a renal ultrasound. One of the renal arteries is normal, and the other was 90% stenosis. That's secondary cause. It's not a primary cause. So that's the difference between primary and secondary. Okay? So the common causes, so we talked about hypertension, hypothyroidism, we talk about drug-induced, we talk about renal disease, but the most common cause is obstructive sleep apnea. Obstructive sleep apnea. Somebody who's snoring, small mouth, very loud, nobody can sleep next to him. You do a sleep study, he's apneic most of the time. When you go and look for blood pressure hypertension, you have hypertension. Screen for OSA. Yes? So an anxiety can cause episodic hypertension, but not hypertension. Meaning, if you give them a cuff at home and ask them to see you to measure their blood pressure, it's not very high. Okay? But you can. Some people are higher risk of having other types of hypertension. We'll talk in a second. So the most common is obstructive sleep apnea. 25% of the causes. Okay. So we push like this. It goes. Next one.
There's an arrow on the bottom.
Arrow at the bottom. Bottom left.
Let's
And
click
then
on the screen.
Tap the screen.
Tap it.
Tap the screen and you'll see an arrow on the bottom left.
Okay. Oh, this is the one. Don't like it. So renal vascular disease, primary aldosteronism is actually quite common, which is Conn's disease. Okay, you have adrenal gland, very hyperactive. You have hypokalemia. So in hypokalemia, so everybody gets renal function tests. These guys, right? So if you see hypokalemia unexplained, you definitely want to make sure these guys don't have Conn's disease. Okay? So drug-induced is another one, is also, but less common. So the most common ones, hypothyroidism, pheochromocytoma. Pheochromocytoma is the most popular cause of hypertension in medical school. We don't see it in practice. If you're an endocrinologist, highly specialized, you'll see very few cases. Real-world practice is not something we see that often. Very, far less common than cons. Cushion is also another cause, but it's less frequent. Okay. Coarctation of the aorta. What is coarctation of the aorta? Constriction of. So it's narrowing of the aorta before the great vessels. Okay, along the aorta itself. It could be before or after the great vessels. And usually 90% of these people who have a coarctation have what other congenital anomaly? Coarctation.
Probably.
What's that?
Notching of the ribs.
What's that? No.
Extra, right?
No.
Yes.
No.
Bicuspid valve.
Bicuspid aortic valve. Bicuspid aortic valve is 100 times more common than the coarctation of the aorta. Usually, most of the times, we have a bicuspid aortic valve, we look for a coarctation, and then we see it. It's not the other way around. And more than 80% who have coarctation will have a bicuspid. So bicuspid is far and away more common than coarctation. Okay. So causes of hypertension, you have genetics, family history, obesity, lack of exercise, increased salt intake, and smoking. Insulin resistance. So these are a cohort of unhealthy behavior. We feel now, in general, if you smoke, you don't exercise, you eat salt, you have bad genetics, family history, you're more likely to have hypertension. That being said, it's so common that it's different to say in a particular patient, a particular person who will develop hypertension. Okay? But healthy diet, healthy exercise, healthy lifestyle is against it. So what are the things that medication cause it? The most common and one of the baddest, worst medications in medicine is NSAIDs. Ibuprofen, all these things, these things can cause a lot of problems. Okay? They were used and very common very early back in the day, so that's why they're over the counter. If NSAIDs were a new drug, there's no way it will be over the counter. What do we mean by over the counter? You go to the pharmacy, you go, I want ibuprofen, you give it that. That's over the counter. If you go there and you say, I want methotrexate, it's over the counter, that's what it means. NSAIDs cause hypertension, NSAIDs cause renal disease, NSAIDs worsens heart failure, worsens coronary artery disease, NSAIDs cause ulcers. These are a lot of things NSAIDs cause. One of them is hypertension, of course. Okay? So NSAIDs, young, healthy person, no comorbidity, that's fine. 80-year-old patient who has a lot of comorbidity, he has osteoarthritis of the knee, you give him NSAIDs, you're giving him a lot of trouble. You may end up in dialysis. Okay? Systemic steroids, very common cause of hypertension. Oral contraceptive pills. Okay? Caffeine is something that a lot of people think is cause of hypertension. In general, caffeine causes palpitation, but doesn't cause organic problems. Okay? So if you get 300 milligrams over 2 lattes or so, it could increase your blood pressure a little bit. In general, caffeine is safe. In general. Okay, antipsychotics and antidepressants. NSAIDs and systemic steroids and contraceptive pills. I for sure want you guys to know these ones, okay? Antipsychotic stuff also causes hypertension. So amphetamine and cocaine, of course, they cause hypertension. People die from hypertensive crisis. Okay, so pathophysiology. So you have systemic nervous system activation, and you have an overactivation of the RAS system. And you have endothelial dysfunction. Anytime you have a problem, it's always the endothelium that's dysfunctional, that's not getting enough paracrine hormones that can regulate things. That's why you have, problems. So you check the RAS system. So when you have, you have angiotensin 1 coming from angiotensinogen, okay, and surface pulmonary and renal endothelium has ACE, angiotensin converting enzyme, and converts angiotensin 1 to angiotensin 2. Renin comes from the kidneys, and this is the cascade. So you start with the renin coming from the kidneys, okay, because of the juxtaglomerular apparatus. You change angiotensin from the liver to angiotensinogen 1. The lungs has ACE, and it converts angiotensin 1 to angiotensin 2, and has a number of other things. So you have systemic activation, reabsorption, excretion of H2O. You have it works in the arterioles, pituitary gland, and also it increases aldosterone secretion in the cortex. So it's a very systemic thing, and that's why when we're trying to treat it, we look for these areas. We come here, here, and here to try to treat hypertension in different ways, to stop the cycle. So, what's the most common presentation? So asymptomatic. The vast majority of patients are asymptomatic, and that's why it's a very bad disease, because you have hypertension, you have it for 10 years, you don't know. All of a sudden you come in with a stroke or heart attack, and then you know that you had hypertension. Okay, but that's the problem with it. Okay, the majority of people are asymptomatic. When you do have symptoms, what are the things you have? Dizziness, blurred vision, headaches, and usually these are signs of end organ damage. So what are the complications of hypertension?
Atherosclerosis.
What's that?
Atherosclerosis.
Atherosclerosis. What else? What's that?
Aneurysm.
What's that?
Aneurysm.
Aneurysms, okay.
Renal failure.
Left ventricular hypertrophy,
Aortic dissection.
aortic dissection,
Renal failure.
renal failure,
Edema.
retinopathy,
Stroke.
stroke. So if we want to say the brain, the heart, and the kidneys are the big three, okay? It affects everything. Everything is affected by hypertension. Healing, a lot of things, okay? But you want to look at the big three. So the brain, you can have a hemorrhagic or ischemic stroke. The heart, you can have left ventricular hypertrophy or congestive heart failure, included with reduced or preserved ejection fraction. Okay, and the kidney, you have nephrosclerosis, renal failure. Okay, so these are the things you can have from hypertension. Okay. So how do you measure blood pressure? So what I want you to know, when you want to measure blood pressure, you want to do it in the correct way. So incorrect way, you have something running, looking for, the lecture here, where is it, to change the location, and then you measure the blood pressure is elevated. Okay? You want to sit down for 30 minutes. No smoking, no caffeine, no exercise, and the last 4 minutes sitting down. So 30 minutes, no exercise, no caffeine, and he's sitting still. You use the correct measure, Okay, so the size in the right place. Sitting upright, the back, feet on the floor, no crossing of the feet. Okay? Relaxed. And when you do that, you average 2 blood pressure measurements. So you do one, you measure a second time, and then that's how you know your blood pressure. Okay, so you want to do it in a systematic way. What's the cuff size?
80% of the length. And
What's that?
80% of the length of the arm and 40% width.
40% width, 80% length. Okay, so the cuff, the actual cuff, not the thing you wrap it around. Okay, pitfalls. So you want 80% arm circumflex, and the width is 40%. You want to be careful. White coat. What's white coat syndrome? What's that?
See the doctor and the other.
Okay, so you come to the physician office, your blood pressure is high. Go home, you measure at home, it's normal. Okay? As a psychological thing, you want to make sure it doesn't fool you. Okay? What's mask hypertension? Yeah?
It's the opposite of white coat.
So it's the opposite, so you go to the physician's office, and paradoxically, the blood pressure is low. Normal. Home is high. So it's like some odd phenomena. So what you want to do is, if the blood pressure is high, you want to do lifestyle modification. You want to look to measure it at home and then see what happens. But if you measure it at home several times, it's elevated, then this is not white coat syndrome. Okay. All right. So what's the investigations? So for a routine blood pressure, hypertension, what we are going to give them? What are you going to do? CBC, lipid profile. Why do you want a lipid profile? Association. What else you want to do? What's that? Urine analysis. You look for proteinuria. Creatinine renal function test. You want to see if the creatinine is elevated. Secondary cause. Electrolytes. You're looking for hypokalemia or hyperkalemia if the patient has renal function, renal failure. What else? Blood sugar. You're looking for diabetes. Screening for diabetes. Very common association. And you want to do a 12-lead ECG. Okay, you're looking for LVH. So these are the main ones. Always want to make sure the thyroid function is normal. Okay, so thyroid function is normal is very important. Now, the secondary one you can do echo, you can do urine analysis, and you can do uric acid. Now, treatment. Blood pressure is less than 120/80. Lifestyle modifications. And normal follow-up. See in 1 year. Okay? So the blood pressure is 120 to 129. Okay, we're calling this elevated blood pressure. It's elevated blood pressure, but you do not treat. Non-pharmacological treatment. Okay? You reassess in 3 to 6 months. So you keep an eye on things. Okay? So less than 120, you're fine, go home, see you next year. 120 to 130, you want to make sure everything's okay, and you'll have them assessed in 3 to 6 months to make sure they're not having hypertension. Okay? Now, if you have stage 1 hypertension, 130 to 139, or one more than 80 to 89, okay? You want to estimate the risk factors. So if a patient has diabetes, has history of stroke, this patient will get treatment. If the patient does not have a high risk, then you can still do non-pharmacological. So stage 1, hypertension, American Heart Association classification, so 130, 130, so less than 140. Initial evaluation, you assess the risk. Cardiovascular risk, 10-year risk. If the 10-year risk is low, then no pharmacological therapy. Okay? Now, if your blood pressure is more than 140/90, which is stage 2, you will always offer non-pharmacological therapy. You'll always say diet, exercise, weight reduction. You'll always offer that. However, you will also start medications immediately. Usually with 2 medication combination. Usually. Okay, so your recommendation is to start with 2 medication combination, small doses, and then escalate the number, and then you can add a third dose, third medication. Okay? So 120, go home. 120, 129, close follow-up, still go home, lifestyle modification. 130 to 139, close follow-up, assess if the patient has ischemic or other high-risk factors. No high-risk factors, then lifestyle modification, close follow-up. If the patient has high-risk features, then pharmacological treatment. If more than 140/90, immediately you go to treatment. Okay? And the treatment is going to be usually started with 2 blood pressure tests. Now, lifestyle modifications, weight loss, every kilo reduction is about 1 millimeter of mercury. So it's small, so below the patient is 100 kilos, lowers it by 5-10%. That's already a significant reduction in blood pressure. A lot of time I stop the medication, or at least one of them. Okay, the DASH diet and sodium, reduction in sodium, and then increase in sodium and potassium. A recent study last week in China, they went to villages, okay, in China, that they use salt. They don't have preservatives, so they don't have ready food. So they went to villages and they gave half the villages sodium, potassium replacements, and the the normal sodium one. Okay? And then they measured them, they followed them for a period of time, and then they selected patients, 30 patients per village, a total of maybe 10,000 patients in each arm. Significant reduction in stroke, cardiovascular disease, and death in patients who received potassium replacement, or replacement to sodium salt. So lifestyle, physical activity, aerobics, and dynamics. So talk about medications. Okay, we're going to talk about medications quickly. First line treatment is what? ACE inhibitors? No. What kind of diuretics? Thiazide diuretics and calcium channel blockers. So 3 medications: thiazides, calcium channel blockers, and ACE inhibitors. Beta blockers, what do you think is about beta blockers? What's that? No, not beta blockers. Beta blockers is not the first line therapy. Beta blockers is not the first line therapy. People are in love with giving beta blockers for hypertension. I have no idea why. No study has shown that. It is recommended officially not. In the guidelines, it is not considered first line therapy. So if you give a thiazide, you give hydrochlorothiazide, you give an ACE inhibitor, if you give a calcium channel blocker, blood pressure is still elevated, you could consider beta blocker as a fourth line therapy. Now a patient walks in and he has congestive heart failure with a reduced ejection fraction, you give them a beta blocker, but it's not for hypertension. If the patient walks in and has a myocardial infarction, then you can give a beta blocker for ischemia, not for hypertension. If the patient comes in with hypertension, the majority of people, you do not start with a beta blocker, you start with the 3 others. Now I want you guys to be aware of the most important side effects for everyone. So for hydrochlorothiazide, it can cause gout, hypokalemia. ACE inhibitors What's the most common side effect? Quickly. Dry cough. So you have dry cough, angioedema is the more serious, but very rare one. If you have dry cough, you switch to an ART. Okay? So renal failure, bilateral stenosis, and hyperkalemia. Do not give it in pregnancy. Renal agenesis. Alright? Now, calcium block, what's the most common side effect? The most common side effects? Lower limb edema. That's not related to congestive heart failure. It's lower limb edema, but it's not related to congestive heart failure. Okay? So then the so you have dihydropyridines, which is amlodipine, and you have the non-dihydropyridine, which is the centrally acting ones, and those you don't give them with patient with reduced ejection fraction. Okay? Beta blocker is not the first. Bisoprolol, it could cause bronchospasm. We'll go quickly through these. Secondary agents, of course, spironolactone is the most important one. We probably want to give that probably before beta blocker, one of the most effective secondary agents, especially with patients with hypokalemia. Probably most of them have Conn's disease. If you give it to them usually for resistant hypertension, it's very effective. But it can cause gynecomastia, which can be very painful. Newer types of potassium saline medication don't do that. Alpha agonists and other ones are usually cause rebound. They're not going to blood pressure control. They have a lot of fluctuation in blood pressure, so you give them and the blood pressure goes up and down. Okay. Okay. Hypertensive crisis. So blood pressure more than 180 or 120 diastolic. If you have end organ damage, that's a hypertensive emergency. Okay? So encephalopathy, pulmonary edema, and those patients don't get to go to home, they go to an ICU. So a patient comes hypertensive, blood pressure 190, and there's chest pain, blurry vision, he goes to ICU. He can have a stroke. Blood pressure, it has to be monitored very carefully. Put an arterial line. So you put a line in the artery and measure minute-to-minute blood pressure. And you lower it down very slowly. Hypertensive emergency. Okay? Hypertensive urgency, this is a guy you're not going to follow up in a couple of months. This is a patient who gets some medication today, see him next week. And the week after, you go and get his blood pressure under control. Okay? So this is the difference. End organ damage is the difference between urgency and emergency. Okay? Right, so conclusion, hypertension is silent but serious disease. It can cause stroke, heart disease, and renal disease. Treatment should be started 130/8 with non-pharmacological treatment. When do you start giving drugs? 140/90. Okay? Second, hypertension is rare but important. Don't be fooled by mass hypertension or white cell syndrome. First line therapy, ACE or thiazides, not beta blockers. Thank you.